full agenda, and I will get into my sort of remarks in a wee while. But just before we get there, we have apologies of absence from Glenn Burley. Glenn had a minor operation yesterday, which went well. So Glenn is off for the rest of this week. Sarah Collette, do we have any other apologies?
We have Mike Wells and Phil Gilbert, and Graham Nuttall's here for the public, but he's given his apologies for the confidential.
Okay, that's super. Thank you very much. Any new declarations of qualification for office or declarations of interest? Please raise a digital hand. Okay, thank you. I can't see any hands raised. The last set of minutes of the meeting held on the 10th of November. Was everyone happy with the accuracy of those minutes? If you have any amends, please raise a digital hand. Okay, I can't see any hands going up, so I'll take those as an accurate record and I'll duly sign. So in terms of action points arising, we had 4. One was on the clinical governance assurance report, which was an update on radiology and pathology, which we'll come back to in a wee while. One was an update on the backlogs in urology and haematology, and the quarterly report was shared with Jane. Thank you, Sarah, for doing that. And then we had an issue about the use of modern technology, which we were talking about in the preamble. That was done, and some recent coverage on BBC Radio 4 was good. And the final was to talk about communication of the returning walking aids to be publicised. I've seen lots of that on Facebook and have been sharing it around, and so that was completed as well. So thank you all very much, team. Were there any matters arising you think I've missed? Please raise a digital hand if you think there was. Okay, I just wanted to say as chairman a few opening remarks. First of all, since the last Council of Governors meeting, it has been a time of immense stress and strain in the NHS system, and I wanted first of all to publicly thank all of our frontline teams at the Trust, in the community, who have done an absolutely phenomenal job coping with a level of demand and a complexity of demand and an acuity of demand that we have not seen in a winter period before. I can't thank enough all of our allied health professionals, nurses, clinicians, consultants. They have all done a phenomenal job during an extremely stressful period. Thank you very, very much. I also want to thank the executive directors and senior leadership team who have given up a lot of their spare time to support the frontline teams. We often praise our frontline teams whilst forgetting the extraordinary efforts, often involving 24-hour working of executive directors with phones beside beds, coping with emergency situations. So I can't thank the executive directors enough. But I also want to apologise to members of the public for the experiences that a number of them will have had, particularly over the Christmas and New Year period. The healthcare system during that period did not provide the level of support which citizens rightly expect of our system. And so I do just want to publicly apologise that despite all of the great work that has been going on at Swift, despite Swift performing much, much better than most other acute trusts, even we weren't able to provide the level of support that we would like to our citizens during that period. So I would just like to note that as well. I'd also like to note that this is Anne Coyle's last Council of Governors meeting. Anne has been a quite extraordinary asset to the Trust over the last few years, both as managing director and allowing the process of integration of our hospital services with our community services really to gain momentum and to lay the foundations for what is the most important next transformation for health and social care, which is through the integrated care systems and a place to integrate all of the healthcare providers to provide a complete package to the citizens. So, Anne, we're delighted for you, but we will miss you. And thank you very much for deputising for Glenn today. Finally, there have been some quite, despite all of the problems that we've had, there have been some very important announcements which are beneficial to Swift, which I'm sure we'll pick up. But we have won an integrated front runner initiative, which allows us to be pathfinding in terms of our work in integrating our community social care and NHS colleagues. And we are also very optimistic about winning a provider collaborative frontrunner initiative as well. And we're very optimistic about that, which will again allow us to build on the work we're doing at Foundation Group to be a pathfinder again in terms of identifying and sharing best practice to drive the productivity that the NHS needs so that we can deliver what we can do in these challenging economic times for our citizens. And finally, Anne and I attended the Integrated Care Partnership meeting this morning. That meets every 4 to 6 months. It was a good meeting, and I think the key takeout for citizens was that both Anne and I were pushing the agenda of hearing the citizen's voice and what is concerning the citizen in the integrated care system. And we are very aware and cited that the key issue for citizens at the moment is the issue of access. And so we will continue to work with systems colleagues to ensure that the issues of access to healthcare services and social care services is at the forefront of everyone's minds. So with that sort of introduction, no further ado, we'll get on to the meat of the business. And the first meaty bit is a series of assurance items, which Harkamel, you're going to kindly lead on. And the first is on core performance in the emergency department. So over to you, Harkamel.
Thank you, and thank you for the introduction. When I was sort of preparing like my thoughts of sort of what I was going to say, I think I said this before, but just to reiterate, the ED performance has been the most challenging, and the acute pressures that we faced have been like something we've never seen before in terms of high acuity, in a large part due to COVID and flu arriving at the same time, and everywhere was really challenged, and we were no exception. So a couple of times we did see some overcrowding, we did experience ambulance handover delays. We worked really hard to try and increase our staffing numbers and bolster where we could, and made sure that sort of everybody was wrapping around this. And one of the things that I really wanted to draw out was something that Sarah coined, which was our compassionate care work stream. And to try and help alleviate some of the pressures that we were feeling, we put together a work stream where staff from across the organisation and volunteers could step away from sort of the back office functions and support where they could on the wards and on ED. And that had a really profound impact, I think, not only on those who were receiving the help, but also those who were providing the help. And a number of our staff stayed after work, even though we gave everybody the option to put down the day job for a moment to help us with our most acute pressures. And I think that's really testament to what this organisation is sort of able to achieve. I just wanted to take the opportunity, though, just to talk you through our recovery for our emergency performance. So I have got a few slides, but I promise I won't take long. But it was just something that I'm really, really proud of. So this data only came through yesterday, and it felt really important to share it with you. So I'm hoping that you can see that. But this first graph just shows our total attendances to Swift combined with Warwick and Stratford. And whilst you can see in the last few weeks they've come down, the attendance rate has come down, it's not massively significant. It certainly isn't statistically significant. So we remain as busy as we sort of ever are. And these are our ambulance arrivals. So it does vary quite somewhat, but it's within like the standard number of ambulances that would arrive to us. If you look at the last few weeks, though, we haven't had. We've had a couple of weeks where we haven't had a single patient waiting over an hour on the back of an ambulance, and we've seen quite a dramatic reduction in the number of ambulances that are waiting over 30 minutes. And this data I'm showing you starts, so that the yellow and the red peak there, that's sort of the end of the first week of January. So this isn't that long ago, and we are still in winter. So I kind of just wanted to share with you just this progress I think that we've managed to make. If you look at the attendances to Swift that have resulted in patients waiting over 12 hours or 24 hours, that's dramatically come down as well over the past sort of 6 weeks. And I think that's just something that I really wanted to draw out, because it's an incredible achievement against the backdrop of not a lower attendance rate. You know, the numbers are what they've always been, and certainly the acuity, whilst it's dropped a little bit, it's not so significant that you'd see some of this. And this is just as a result of everybody's hard work. And you can really see the knock-on of that on what our 4-hour performance is. So this graph here just sort of trends through the weeks from the 4th of December in terms of what our 4-hour performance looks like. And I'm really proud to be able to say that today we found out that we have moved back into the upper quartile for our 4-hour performance, and are 27th out of 118 organisations. So by way of recovery, the organisation is demonstrating quite a few strong pockets of that ability to kind of bounce back. We are by...
Has Harkamel frozen for others as well?
It is still December, February, it is still winter. We are still worried about the acuity. We are seeing COVID numbers rise around us in some of the organisations. So it's just really important to not lose focus of, you know, the challenges that we're facing, but really celebrate some of the pockets of success. So that's my update on the emergency department.
Okay, Harkamel, I've popped into the chat box for governors to ask questions at the end of all of the assurance items, just so we make sure we keep reasonably to time. So do you want to move on then to elective recovery, please?
Yeah, so by way of elective recovery, we have managed to maintain our elective activity over the really challenging last 8 weeks, and that was under against significant pressure to cancel some of our activity. Most organisations across the country were cancelling their electives, and we never did. We had made a really proactive switch to day cases way in advance of all of this, because we knew that pressure was coming. We did do some ward moves in between to try and reduce some of the footprint for elective and increase it for medical, and we did that sort of in December, but by and large, I think we did really well. And I think the success story for elective is that we haven't had for a while, and we remain with no patients waiting over 2 years for treatment. We are on track for the waits to come down below 78 weeks, which is has been nationally mandated. So organisations are expected to have no patients waiting over 78 weeks by March, and we're on track to do that. And actually, we're now looking at 52 weeks. So that's where we're tracking to try and get back down to a year. You'll remember that, pre-COVID, a patient waiting over a year for treatment, we considered it as a never event. So I'm really pleased that we're able to get back to that. By way of cancer, we do continue to see the rise in cancer referrals. So I've said before that we're seeing unprecedented levels of demand. And over the last year, there have only been 2 months that we haven't seen record numbers of demand, record numbers of referrals. So, and even those 2 months, we saw the highest that we've seen in the last 5 years anyway, or the same number as the highest that we've seen. So the referrals are just massive. But, I think that's a really good news story. It's really important that our patients do keep coming forward. So by no means are we trying to discourage that. We're just working really hard to modify some of our pathways to work to try and get patients through sooner. The colorectal pathway is the biggest one for that, to try and get patients straight to test. The next update I was asked for was around radiology. So I was asked for around a specific question on pathology, and it was just to say that we haven't seen any adverse effect of the way that the consultants are working or any changes with that. We have recruited 2 new pathologists, and they started in January just this January, which has been brilliant. And we're working quite closely with Wye Valley so that we can support their pathology service initially, but also to see if there's anything that we can do in a more joined up way. From a radiology point of view, the national pressure with radiology is workforce. We're by no means an exception, but we've managed to really see the fruits of the labour in terms of some of the overseas recruitment that's been going on for 3 years. That's really helped us. So they've managed to increase the workforce by around 29% over the last few months, which is brilliant because they have been really, really struggling. And our performance, we've been ranked #1 in the Midlands in terms of diagnostic performance. And unfortunately, we've dropped to position #5 nationally. But that's just the unprecedented demand that we've seen. And actually, isn't that an amazing thing to be able to say that that's sort of what we're worried about? So I'm really, really proud of our team in radiology. They've done a phenomenal amount of work to get back to where they need to, and have really been like the backbone of some of our support with the emergency pressures. I think my next item is just around patient-initiated follow-up, and I was asked around, specifically asked how patients are identified to go onto a patient-initiated follow-up. So this is a clinical decision, and you don't ever move a patient onto a PIFU unless you've discussed it with them. So typically a patient will come in or have their virtual conversation, and then they are asked if they are stable and feel that they would rather go on to a patient-initiated follow-up, and then they make the decision either to move across or to stay on a scheduled follow-up. It works really well for the specialties with the chronic conditions. You know, those patients tend to know how to manage their condition, and I think, you know, if we're thinking about how we move forward, giving that ownership back to the patients about managing their conditions, and for us to be as flexible as we can feels really important. And in terms of how patients get back into contact, it depends on the condition. So they'll either be given a period of 6 months to say, you know, if you don't need anything within the next 6 months, we'll discharge you because actually you're more safely managed by your GP. And you might be discharged to having a PIFU, you might be just a standard PIFU with a timescale, or you might be put on a PIFU and then reviewed after a year, and then we collate the list of those patients. So that process is embedded. We currently have around 2.7% of our patients on PIFU. So the numbers aren't huge, but we're certainly working on trying to pull that up. But they are in line with what other organisations are seeing. And we are really cognizant of that, actually. What we don't want to do is just, you know, make a blanket discharge to a GP when people have become more poorly on waiting lists. And so it's really important that we continue with that dialogue with patients. And that work will continue into next year. I think that's my updates.
No, fantastic, Harknell. You've done a phenomenal job with Sarah and Moppet and Bhaskar in particular over the last couple of months. So thank you collectively for your hard work, and a real demonstration of the agility which we've engendered in the teams, and a big call out to Rachel Williams in particular, the ED department, for the work she's done. So before I invite questions, the final request from governors regarding assurance was on 7-day working. So Anne, I think you're going to cover this.
Yes, thank you, Chair. So the board assurance framework for 7-day hospital service refreshed guidance was issued on the 8th of February 2022. So that means that provider boards like ours should assess once a year whether the acute services are meeting the 4 priority 7-day service clinical standards against those. And those are the first is access to consultant directed assessment, second diagnostics, third interventions, and fourth ongoing review. A 7-day service report signed off by the Chief Medical Officer will be presented to our Board of Directors in March. And the content for that report, so it's on the annual plan for our auditors, and that'll be drawn from our SIPRA consultant job plans, deep dives into areas of concern, wider performance, and also patient experience measures.
Super, thank you very much, Anne, and I'm delighted we've now got a member of the public in the form of a Boston Terrier joining the Council of Governors meeting. So that's the update. We've got some time for questions. So questions or perspectives from governors. We've got about 12 minutes for this. Roger?
Yes, I'm sorry if I missed it, but radiology and pathology was on the minutes for Glenn to respond. So I suppose it falls to you, Anne, to give us a comment as to what progress is being made on getting things back up to back up to normal service.
I think Harkemel did cover that, but Harkemel, anything you want to add to what you said previously?
No, so on top of the 2 new pathologists that we've got, the work still continues around digital pathology. I think that will really help the departments. We meet regularly with the pathology service in terms of tracking where we are by each different modality and seeing if there's any other progress that needs to be made or any other changes. And we're seeing some data now to help us track some of that. But other than that, I don't have any further updates.
Okay, thanks, Harkemel.
Thank you.
Mary Moore?
Yes, about PIFU, patient-initiated follow-up. Are patients given a direct line telephone number so that if they ring in because they have an issue or they want a new appointment, they can access that just on one phone call to an appropriate person?
No, we can't do that in terms of the way that the phones are configured with Netcore. So they are given access to the booker to book via that, and their access plan is already built so that when they call in, it's clear that they're on a patient-initiated follow-up, which is sufficient. So there's no other hoops that they need to jump through. They'll just call as if they were going to call to respond to a letter to book an appointment. And then for some patients, they have an email of a specialist nurse that they might choose to go to before they book in for an appointment.
So they're given the instruction, they're given the number to ring the booking department, and and that's just that one number, and they'll get arranged through.
Yeah,
okay.
yes, yeah.
Okay, thank you.
Thank you, Mary. Thank you, Harkemel. And Jean?
The fact that we're part of the ICB, if we reach our targets, will we still be detrimentally affected if they aren't reaching their targets? You know, you mentioned how we were reaching our targets. Are we able to stand alone financially, or are we affected by them?
No, I don't think we are we, Kim, on that particular issue? Kim?
No, yeah. Do you want me to come in on that? So no. So the system's confirmed that there's no clawback in terms of elective recovery funding that we allocated to the system for non-delivery for this financial year. But we do need to maintain our productivity levels moving to next year as we move into back to a PBR world on elective activity.
Yeah, no,
right. Thank you.
Thanks, Jean. A big opportunity for us next year, the move back to PBR. Some trusts don't like it, we love it. It's an incentive for driving volume harder. Emma's just dropped something in the chat box, which governors might find helpful on PIFU. We now go to Calais.
Yes, thank you. Thanks, Russell. Yeah, my question has to do with electives, and is the national guidance, I know the trust is trying to not have 78-week waiters. Is there any guidance on how do you break down the waiting lists? Like, what are your thresholds? No more, and is it percentage that you use? That many patients are waiting for 50 weeks or whatever. Do you have that sort of data? And is it any national guidance or whatever on what sort of percentages should wait over 50, over whatever the case is? That's my question. I know you mentioned the 78 weeks, but and obviously which specialties may have a bigger problem? Is it which surgical specialties may have bigger problems when you look at the data? That's all.
I was going to say, I think it's pretty binary, Callie. There should be no over 78-week waiters. It's not by specialism, but we do have the breakdown by specialism in terms of where our biggest challenges are. Harkemel, do you just want to indicate where our biggest challenges are?
Yeah, so our biggest challenges are in orthodontics, and that is because we're the only provider of that specialty within the system, and everywhere is challenged nationally on that. We are also a little bit challenged on plastics, and that's because these are single figures, so it's not nowhere near the scale of what other organisations are seeing. But for us, I'm looking closely at plastics, just because we've seen quite a significant increase in cancer demand. So it's just being careful around balancing the treatments for both. But we've only got 3 of those at the moment, so it's just about keeping an eye on that. And in terms of your question, so yes, we do have lots of data. There are lots and lots of national rules. We've been doing RTT for a really long time. Last year, they confused things a little bit in terms of looking at clock stops, which is something we used to do years ago. But thankfully, next year, it's just back to the usual RTT rules. And in terms of the 78 figure, it's exactly like Russell says, it's a 0, not a percentage. We also are looking at all of our referrals, and you can see now how many are going to breach by the end of March, how many are going to breach by the end of August, or wherever. And so we've got lots of different reports set up so that we can see when people are tipping over and if there are any pressure points that sort of might be building up.
Okay, thank you. Thanks.
Thank you, Callie. And finally, David, and then we'll move on. David G.
Thank you. There was an article on the television this morning which reflected this general improvement in ambulance and ED figures, and no one could understand why. Do you have any thinkings on this?
Yeah, so I'd be interested in Sarah if you've got a view as well. But my view is when we reflect on December, the acuity was so high. We had not seen an ED department carrying that level of risk before. We just hadn't. And in terms of when you're thinking then about where to flow out, when you're dealing with that level of acuity, we had to maintain safety. And so I think there was part of that was our issue, certainly at Warwick. We continue to work with our ambulance colleagues around the pattern in which they send ambulances to us. And we are often affected by ambulances out of area. And when we start to get really challenged in terms of the handover delays, that's usually because we've had, 8 turning up at one time, for example. We don't offload that. We just don't have the space in order to process some of that. So when you sort of track back, that was a certain cause for us. And we work quite closely as a system. So if George Eliot are struggling and UHW are struggling and we are struggling, we try and manage some of that demand as closely as we can. That's really challenging when you're then getting ambulances from, we had some from Gloucester, some from the east of England. It is trying to map all of that demand together was really, really challenging in December. We also had a lot of sickness. It wasn't just, patients turning up with flu and COVID. We had staff off as well. And, whilst we remained safe, we were challenged, and then that will affect some of the turnaround times as well. But the acuity was reflected on the other end as well. So there was limited ITU capacity. So we were thinking about where we could set those patients down to. And when we thought about our ward configuration, we had to make some changes to make sure we had enough capacity for that. But Sarah, I don't know if you... So for me, in terms of what the improvements in the ambulance handover turnaround times have been more sustained staffing levels, less batching of ambulances, so a pattern that we can actually manage more effectively, and a lower acuity despite some of the numbers being the same. So we don't have those, we haven't got the pressure of isolating all the COVIDs and all the flus in the same way that we were juggling in December. So flow is a little bit easier. We've also, sorry Sarah, I know I brought you in, but I've just remembered something else. We've really focused on some of our same day emergency care pathways, so surgical assessment unit, the acute decisions unit, and really trying to stream patients through. We didn't have the benefit of that in December because everybody was so poorly, and we needed to be careful about where we were putting our infectious patients. So our capacity to be flexible had reduced, and we've got some of that back now.
Very comprehensive answer, Harkamel. But in terms of the stack, though, which I think was the other element of David's question, it is a bit of a mystery. I think it's fair that the way the stack has fallen. Sarah, any idea from your perspective why the ambulance stack has fallen?
I think December was a really extraordinary month, as Harkamel has clearly described. And the thing that was different about this winter was that we had a very early flu season, and that flu season coincided with a wave of COVID and with RSV. So I think one of the reasons, and that was what led to the very high acuity. So I think one of the reasons why, and the NHS was in the press almost every day, wasn't it, in December? And I think that was due to high acuity and therefore high, a lot of type 1 attendances at A&E, and I think that's what led nationally to the very high volumes of poorly patients in A&E and some of the flow problems that led to organisations finding it very difficult to offload in a timely way, and that ambulance stack building up. But I also think Harkamel has really clearly described one of the reasons why our improvement has been so significant in January is partly because the acuity has reduced, because we've kind of got past the peak of flu, and it's sort of second week of January, literally the bottom went out of flu and our numbers went right down. But it's also because we have had such a concentrated focus on improving our flow and our turnarounds and all the ESTEC work and all the things that Harkamel has described. So it's those two things for us which have made such a huge difference.
Thank you, guys. Really comprehensive answers. Thank you, governors, for your questions. But we'll move on now just to get us on time. So we're next on to the operational assurance, which we've been talking about for quite a while, with the historical view for Q3. And what would you like to pull out of the report, please?
Yeah, well, I suppose the first thing to say is that, it is good progress that we've made across all of our objectives. And Len reminds me that, it shouldn't be fully green, because if it was fully green, then it wouldn't have been enough stretch set at the beginning of the year. But to draw out, I suppose, Objective 9, the implementation of the national strategy operating at place, there we have a red around the development of the lead provider model. And it is a source of disappointment that we haven't been able to progress and mature our capability as a lead provider beyond the out of hospital services. We hope, and the chair mentioned this at the beginning of today's meeting, the work that we're doing on a discharge frontrunner site progress, that will help with us taking on more commissioning responsibilities, more delegated responsibilities from the ICB. But also, and part of the reason behind our provider collaborative innovator bid, and we'll touch on this late in the confidential section as part of the strategic update, but that is another reason, and that we hope affords us opportunities to progress. Also in the questions, if I may, moving on then to workforce, just a question around succession planning, and really draw colleagues' attention to the work underway around on our succession planning across our executive team, but also across the whole organisation. Again, it's pleasing to see the progress that we're making on workforce, and notable that we're still awaiting the publication of an NHS workforce strategy, but very much work has really been, a lot of work has been very much underway on that. And then finally, just in terms of the commencing the implementation of a new electronic patient record system, just really to draw out that the full business case is very much in progress, and we hope to consider that at Board of Directors in March. There are some risks, and they're flagged onto the board assurance framework. Happy to take any questions.
That's great, thank you, Anne. So any questions to Anne on the operational assurance quarterly status report? Callie?
Yes, thank you, Anne. I just wanted to ask, there is you managed to appoint, is it the cancer navigators, I believe, and that's a new role to sort of to help with the cancer care pathways. And are these what sort of background these people have to facilitate the process? That's one question. I had a couple of more questions, but do you want me to ask everything or?
No, it's fine. If I may, okay. Sarah, you have implemented the work on the cancer care navigators, just in terms of the background of those colleagues.
Okay, did you have a couple of other quick questions, and then I'll move on to
yeah, the other is about the Warwickshire Place plan, and is that has been decided by the integrated care board, the plan, and can we have a copy of that? Has that been shared with us? I can't remember, but it's somewhere it's mentioned, the Warwickshire Place plan. That was the other question. That was all. And the final question is that
bit by bit, Callie.
Okay.
So, and on the Warwickshire Place plan, has that been publicised?
Yeah, the South Warwickshire Place plan has been publicised, and absolutely can circulate that. And in terms of the ICB, obviously, they're working on a wider integration care plan across Coventry and Warwickshire. So they all do align and they do interconnect. But again, we can circulate those documents after the meeting.
Okay, yeah, that's fine. Right. No, the last question is the new EPR. I know it goes to board in March, the business case, but would that be Lorenzo, or it hasn't been decided, or what sort of software they intend to use?
Okay, so having gone through a procurement process,
Okay.
yes, we have identified a preferred supplier. It's a supplier across Coventry and Warwickshire. It's called Cerner. Lorenzo's
Okay.
our current provider. And we
Okay.
will be.
Thanks, Callie, and keeping the pace going. Roger? Roger, you're
Sorry.
still mute. I'll try.
There we go. Right. In the item 6 of Anne's report, there's reference to a memorandum of understanding about appointing the Warwick University Medical School to the foundation group. Is this an associate membership, or is this full membership, or all a third breed?
No, this is around the appointment of the non-executive director.
Right.
So
right.
that covers that appointment, not necessarily that we've got Warwick Medical School as an associate member of group.
Right.
So-
Fair enough. Okay. Thank you.
And Mary?
Yeah, just a quick one. In that item 6 as well, it mentions the research foundation group strategy. Is that document available to us?
Well, that's
Yes, that has.
circulated, I think, previously on the board papers.
Yes, it's in the public domain. It's
Oh, it's in the board.
Yes, it
Okay.
went. It has been circulated and it is in the public domain. But again, we can make that document available after the meeting.
Perhaps we could get some of these documents put into admin control.
Yeah,
Sure.
it will be an admin control, as ever. Admin control is a bit like a labyrinth on occasion, and it's finding where stuff is. And finally, Mike, then we'll move on.
Yeah, it was about the cancer care navigators. It's a bit off the wall, but I wondered how our cancer care navigators deal with patients that are receiving their cancer treatment at hospitals outside of Warwick.
Great
Say
question.
the QE or something like that, because from my own practical experience, there seems to be no link at all.
Yeah, no, great question. Harknell, do you want to answer that one, or?
Yeah, so just to answer the other question, the background of the navigators are basically administrators, so a really diverse range of backgrounds. And essentially, Mike, that's why we've put these people in, to be that point of coordination and help, signpost patients to the right place, but also to help them navigate their journey through the pathway. So they are that person who can, support people in making sure that their scans are done before they come for an appointment, but also help them to understand what's going on. But they are that point of contact. If a patient goes to receive their, radiotherapy at Coventry or surgery at UHB, that's the point of the navigator, to be that one single point of contact who can help coordinate and navigate.
My wife's getting treatment at the QE and she's had nothing from anybody in Warwick about care navigation. None at all.
We'll
Been active for 2 years now.
Yeah, we'll take that up outside.
I'll take that.
Yeah, we'll take that.
Sorry to raise a personal issue, Russell, but it just, as it came up, I thought I'd ask.
Yeah, no, very fair. Okay, so Harknell, I know you'll pick that one up for me. But that's the intention, Mike, and I think it will be important to see how it works in reality. Colleagues, happy to move on to the patient experience assurance report? Okay, thank you. So Sarah, over to you.
That's great, thank you. So if I may, I'll just start with an apology because the paper only outlines data up to the end of September. And I think the honest answer to that is we got slightly caught out with the way that we've now got foundation board meetings. So this paper went to board in December. But what I thought I would do is much in the way that Harkamal has described some of our recent performance. I'm going to use recent examples and describe some of our data from December and January as I pull out some of the key points. So overall, I'm really proud to be able to say that our patient experience data remains extremely positive, and that includes recent months. Our complaints data is pretty stable. And I think the really important thing to draw out from the complaints data is there's no one clinical area across the organisation which is standing out, which is, you know, had a big peak in complaints or red flags that you may want to really dive down and see what's happening in that area. So that's really good news for Swift. So in November we had 10 complaints, in December we had 17, and in January we had 9. So December was a bit of a peak. When we've looked back over previous years, it does seem that we do normally have a slight increase in December, but I'm not sure it would necessarily even be statistically significant. But I think there is a challenge for us in how do we avoid that peak each December. I don't know whether it's anything to do with Christmas, but in January, I think the good news is that we only had 9 complaints, and that's the lowest number of complaints that we've had for 6 months. So I think that is very much linked to the discussion we've had earlier on in the meeting around our improved operational performance and our improved emergency flow, because we know that when we have flow and we treat patients in a timely way, that goes hand in hand with them having an improved patient experience. So although our complaints remain overall low, what is really important is how we respond to them when we do get them. And although our KPIs for, you know, the things that we measure in terms of how quickly we respond to complaints, etc., remain strong, I just want to share with you a piece of work that we've done in the last few months. So we've been looking below the KPIs at the little things that make a difference to patients, that help patients to feel that we've really listened and learnt from their complaints. And the patient experience team have been running some training sessions with managers, and we've been encouraging managers to make sure that they reach out to patients when they've complained at the earliest opportunity and have that one-to-one verbal conversation to really understand what it was that patient was concerned about, so that we can make sure we understand the complaint in detail and can take all reasonable steps to address the concerns. So the report has detailed some concrete learning that we've taken forward in response to complaints and concerns. But if I may, I'm just going to talk a little bit about A&E, because you'd be quite right in asking me the question, how has patient experience been in our emergency department over the past few months when it's been under so much pressure? So as Harkamal has already alluded to, one of the things that we did through our Silver 4 times a day operational oversight meetings is we set up what we very proudly called our compassionate care work stream. And that was really aimed at helping all of our teams across the organisation focus on the needs of patients and how we could make patient experience as good as it possibly could be at a time of really extreme pressure for the organisation. So Harkamal's already stolen my thunder actually and described some of the things that we did. But in terms of A&E, that led to us putting a hostess on duty 12 hours a day, 7 days a week, so that we were able to provide meals and refreshments in a timely way. We also had 24/7 hot drinks trolley provided in the department, and we moved to a model of 7-day volunteering. We had 70 of our own staff that came forward to supplement the wonderful service that our existing volunteers already provide. And we also focused on really embedding hourly rounds in our A&E department. So that's where the clinical staff make sure that every patient, every hour, receives a welfare check in terms of how they're feeling, are they comfortable, do they need any food, drink, etc., how they're feeling, how their pain is. So the really good news to say on the back of that is that in January, we have seen an increase in positive comments. And I've got a list of them in front of me, but the first one on the list I just want to share because I think it's such a tribute to our staff over what's been a really difficult time. So it says, my care, treatment, kindness, everything was absolutely fantastic. I felt comfortable, safe, and always well informed about everything, always being asked if I was okay and comfortable. I could not thank them enough, all of the staff. Thank you so, so much. And I felt quite emotional when I read that. So in terms of our family and friends data, again, that remains consistent. November was 92.1%, which was an increase on previous months of overall good or very good feedback. Again, we did see a dip in December, so it dipped down to 89.6%. So that's a reasonable figure when you compare nationally, but I think that is reflective of the pressures. I haven't got January's figures, they've not come through yet. So the final thing I just wanted to end with was, just as we near the end of the financial year, we completed a full cycle this year of all of our wards going through our ward accreditation programme. And that programme looks at metrics right across all of the domains, but it has a very large element of assessment of patient experience in that clinical area. There's always a patient rep on the assessment panel, and we look at not only what the local data for that ward is, but also how that triangulates with observed feedback from patients and staff during the assessment of that ward. So the final scores on the doors for SWIFT were that one ward, Greville Ward, was accredited at the top status, so it received exemplar ward accreditation. And then we had 9 wards that received outstanding and 14 good. So I think that's something to be celebrated. We are having a Care Excellence Conference on the 9th of May, which is in between Midwives International Recognition Day and Nurses International Recognition Day. And we're doing that as a foundation group. So Wye Valley and George Eliot also taking part in that Nursing Midwifery Care Excellence Day. So I'm hoping that they'll be celebrating lots of the examples of improvements to patient care experience during the last year. So I'm very happy to take any questions.
No, thank you, Sarah. That's very comprehensive. One of the things that governors know I am keen on is the patient experience, the way we look at patient experience and gain assurance as a trust and as a board of directors are nationally mandated very often in terms of the requirement. I want to make sure that we hear the broader voice of how citizens are feeling about healthcare delivery. And as I referred to in my introduction, Anne and I attended the Integrated Care Partnership meeting this morning, and Chris Bain from Healthwatch Warwickshire talked about the 6 key things which patients and citizens were feeling about the health and social care system, and I thought I'd just share those with you. The first was a deterioration in trust and confidence, mainly related to an inability to gain access face-to-face through GP practices and a concern about digital exclusion. The third concern was around health inequalities in the way service was provided and health outcomes and cost of living. The fourth was delays in assessments, diagnostics and treatments. The fifth was around access to mental health services. And the sixth was around the reduction in provision of NHS dentistry and the problems with access to pharmacy. So despite all of the great things Sarah's talking about in terms of the work going on in the Trust, I think it's important for us as a Council of Governors to hear the voice of our citizens generally, and Healthwatch is going to be very helpful to us going forward. We want to find a way of getting Healthwatch far closer and briefing us far more often on their view on how the public are feeling. So, questions or perspectives to Sarah on our patient experience assurance report, please. Mary?
Just a quick one. Who carries out the ward accreditation? Is that as in-house, presumably?
Yes, it is. It is in-house, Mary. It's a whole team. It's a whole multidisciplinary team. So we try to make sure we've got people working at different levels in the organisation and in different disciplines. And there is always a patient representative on the panel. Actually, one of the things I put in my notes and I forgot to say, so thank you for the reminder, is Ellie asked me to convey to the Council of Governors if anybody would like to join any of the accreditation visits during the next year. If you just drop Ellie or I a line, then we would be delighted for you to join one of those visits. It's a really great opportunity to see the work of our clinical teams firsthand. So we would welcome that.
Sarah, can you just drop Ellie's contact details into the chat box as we're talking? Thank you.
Yes, of course I will.
Then Callie, and then we'll move on. Callie?
Yes. Yes, thanks. Thanks, Sarah. Yeah, my question has to do, obviously you have a pie chart when it comes to the PALS queries, and the three big areas are appointments, communication, and other. What comes under other? And I know there were some examples of partially upheld complaints, and you did identify some of the complaints, but what usually comes under other? Just a couple of examples. You don't have to go into details, but it's a big chunk in the pie chart that says other. That's all.
It's all sorts of things, actually. I don't know how to give you some more details on that. Maybe in the next report we'll try and break down others a little bit more and see if we can give a slightly more detailed narrative around it, because I mean, one of the things we've seen, particularly since COVID, is most things are related in some way to communication. If we can just get that communication element right. And so that's one of the reasons why we've chosen communication as one of our quality priorities for next year. So that means different things to different departments. So for outpatients, it might be making sure that we've got absolute clarity around follow-up appointments. For radiology, it might be a different element, but we'll be using a lot of the PALS patient experience data and some of the sort of the detail in some of the other coded inquiries to make sure that we cover as much as we can in that quality priority.
Okay, thank you.
Callie. Okay, we'll move on now then to the clinical governance assurance report, and in David Spraggett's absence, Sue's kindly doing that. So Sue Whelan-Tracy, over to you.
Thanks, Russell, and good afternoon, everyone. Yes, I'm presenting the reports from the committee for October and November. As Sarah mentioned, they're similar to other reports, they're slightly behind, but just wanted to reassure you that we are meeting as normal as a committee across this busy time. We have had some truncated meetings because of pressures, but we've been seeing the usual monthly reporting. And in addition, I wanted to make governors aware that now we see maternity quality reporting every month. That follows the extensive requirements post the Ockenden, East Kent and East Kent inquiries, and also the ongoing progress that the Trust is making against the Saving Babies Lives Care Bundle. So each month we're looking at the considerable amount of work underway there and how our compliance with that is improving alongside very heavy demand, because maternity numbers are significant currently. So we've seen, as usual, the quarterly divisional clinical governance reports. We've seen emergency care, elective care and out of hospital divisions. I think it's fair to say that as pointed out in the reports, the main risks are around available staffing and recruitment issues. And we've looked in depth at some of those with the specialties, and I'm pleased to say that there's a huge amount of activity underway to retain and support our staff as well as recruit. Some of those areas are very challenging. We've heard from Harkamel about radiology, I think it was, and there are some challenges, for example, in haematology, and there's a clinical summit in the next few weeks in order to positively respond to some of those issues. I wanted to end on the other issue that comes through the two reports, which is around IT risks. I wanted to point out that the committee is now very mature, that we have Innovate attend the committee and assist us with our understanding of how risks associated with IT are being managed. And across both, I think it was October and just this week in January, we received the report on the Results Acknowledgement Project, which governors will be aware has been a red risk on our board assurance framework for quite a significant number of months. And I wanted just to acknowledge that that project is about to move into implementation, which is great progress. So overall, the committee are significantly assured of the standards of safety across this exceptionally busy time.
Thank you very much, Sue. Any questions to Sue? Okay, very clear. Thank you very much, Sue, and thank you for all the work that goes on in the background, Sarah, in terms of providing the information for QAC. Kim, you've got a lot to cover, not much time to cover in it, so we'll take your reports as read, but what would you like to brief us on in the finance assurance report, please?
Yeah, thank you, Chair. So most of the items on the agenda have been covered in the main report. But if I draw out a few things, so as we've discussed, the month 9 position has been very challenging operationally, and this has had an impact on an increase in our expenditure run rate for December. But we have maintained a year-to-date break-even position despite those challenges, which is great news. Key thing is that at month 9 we're still maintaining that we're going to forecast or try to deliver the plan of a £3 million surplus. But as we've already discussed, there are still operational challenges with the remaining quarter, with continued pressures, including strike action and inflation and other risks that we are still working on mitigating. However, as I reported at the previous Council of Governors meeting, as of today, with 2 months to go, I'm confident that the Trust will be able to deliver a break-even position or better by year end. So I will maintain that at current times. A key thing of focus is agency spend, which is a key driver to our expenditure run rate. We had a good, robust discussion at the 3 boards meeting the other day around agency and how we can work together on reducing our agency expenditure. And I'm aware that governors have also had separate conversations around understanding how we manage our agency staff as well. Our capital programme has increased significantly because we've been successful in a number of bids, which I will go on to talk about further in the confidential session. You've asked for an update on our subsidiary companies, which is in the report. Just wanted to highlight there's been since writing those reports, there's been a deferred tax issue that is currently being worked through by Swift CS. So I just want to flag that as a potential risk. But otherwise, I think everything else has been covered in the report. So happy to take questions, Chair.
Thank you, Kim. This is our toughest financial year we've had, and we need to ensure as we leave this year that we enter next financial year really driving productivity very hard. We have spent far too much this last year on agency costs. Over Christmas and New Year, that was essential spend to stay safe, but we need to stop the leeches of these very expensive agencies as we go forward. So questions and perspectives to Kim. Roger?
Thank you. I noticed, Kim, in your report that you've shown that CPIPs are getting within touching distance of achieving success, allowing how difficult it's been over the last 2 and 3 years almost to achieve these. Do you believe there is going to be more scope to do more for next year, or have we scraped the barrel on absolutely everything that we could possibly do here?
I think it's fair to say that there are still opportunities. We've already done a significant amount of work at reviewing what those productivity opportunities are, and they've been shared with the division. It's clear that that a significant amount of investment has been put into the NHS, and we now need to get back to the productivity levels that we know we are able to deliver upon. It's not without its challenges, but with willing and working together, then that's the key thing, really, isn't it? Getting key engagement really and be clear around what we can do and work together on achieving that. And Harcombe, Sarah and I are very keen to make sure that we all work together on delivering that for next year.
Thank you.
What really encourages me, Roger, is the level of positive attitude and innovation and desire to transform in all the teams across the whole of the foundation group. But if I can just give one example of where I'm ambitious. Across the foundation group in 22-23, we will spend close to £50 million on agency cost. Assuming conservatively a 25% margin, that means we are losing £12.5 million of pure profit or surplus, which should be ours if we paid, even if we paid all of the agency staff what they're currently paid. So agency cost is an enormous opportunity for us, which we're going after. Callie?
Thank you.
Yes, thanks, Kim. Just a clarification about the capital program and capital spending. Obviously, you have to use abbreviations like PDC funded schemes, performance and actions, that section of your report. What are the PDC funded schemes and the CDL funding, and this program, and what allocation, or is all the capital funding, the trust's capital funding, it comes under the integrated care system? Is it at that level that they decide how much it's of the poor providers gets? Is that how it's all done? And that's I'm asking.
I was on mute then. So the way it works is that the ICB are given a system allocation, and we would negotiate our share of that system allocation that we need to live within. But in addition to that, there are separate pots of money, shall we say, that we as individual organisations can bid for specific purposes, and the elective hub is an example of one of those.
Okay. Right, but the majority of the funding, capital expenditure, comes through this route, the integrated care.
Yeah,
the majority would come through this route, but we also are able to use charitable funds, but most definitely it's through that route, or for bids for additional funding where we would get additional cash.
Right.
Yeah, definitely the case, Ali, that as we've talked before in this forum, a number of the freedoms of foundation trusts have been taken away over the last few years, and this is one of them which causes me the most concern. Ruth?
Kim, I'm just wondering, with the new build, redevelopment, perhaps starting quite soon, is this going to have an effect on our productivity and our costings?
Certainly hope not, Ruth. And that's one of the challenges for the team, just sort of interrupting for Kim. We can't afford to go backwards on productivity. So the teams need to do this stuff and find ways around the potential disruptions. But next year is a year of opportunity for us as a trust with the move back to payment by results. But more importantly than that, too many of our citizens are waiting too long for the elective services that they require. The waiting lists are too high. So even though there's a financial benefit to us of driving down those waiting lists, our primary concern, as Harkamel's indicated, is we want those waiting lists down because we don't want our citizens to wait. And anything that affects productivity keeps those waiting lists too high. It's worth remembering that Swift is about 15% more productive than the average acute of its size. And certainly when Tim Briggs and the GIRF team have compared our different services with providers around us, Swift, in the majority of times, Swift is substantially more productive than other providers around us. So it is a risk, but we can't afford to allow it to crystallise. Kim, is there anything you wanted to add to that?
No, I don't think so. No, thank you, Chair.
Thanks, Kim. Thanks, Ruth. Okay, colleagues, if we move then on to the audit assurance report. Richard?
I'm off mute, thank you. Hello, everyone. Just a couple of points. I'll take them as read, a bit like some of the other committees because of the timeframes of when things come through. It says 12th of October, which is the last meeting that's gone through the approval of the next meeting of the audit committee, then the board. There's been no board. So there have been other meetings on the 14th of December and 8th of February. One of the questions Roger asked about radiology, there was a report yesterday at the audit committee which looked at MRI and ultrasound, just to say that the internal audit came up with a significant assurance on the work that was done in that department. But some of the common themes we've had in the last two audit committees is where we have problems with the internal audit reviews, a lot of it comes down to EPR. You know, the current Lorenzo booking system is not fit for purpose. You know, for example, we're talking about electronic pathways records. If you have a new consultant from the one that started the process off, it takes an average of 15 minutes to change that record for somebody else. So that's just an example, and those things will come through in the next month or two coming through, but there's been some good reports there. We reported on the delays to last year's accounts. Most of the main accounts, there's a lot of work going on to make sure we don't have delays this current year, but we still have a number of delays from last year due to staff illnesses that's causing the problems. And part of the tax problem with the Swift Clinical Services is the fact we've only just about signing off the report now, and that's given a lot more time for people to look at the tax records. So that's part of the reason why we've got problems within there. And I think that's probably about it. The only other thing is that one of the concerns I had yesterday, that we had the 6-monthly update on from our team about local security. And one of the issues we've got, there has been a significant increase in physical and verbal abuse of our staff over the last year, and I'll report back later. But I think post-pandemic, people's tolerance of people has gone down. So people are getting very upset and angry, and ED carrying out that performance over December and January, on top with having to deal with all the verbal abuse and even physical damage within the emergency department has been very good. So I'll take any questions.
Thanks, Richard. Just on that last point, I just want to be very clear on this as the Chairman of the Council of Governors and Chairman of the Board of Directors. It is unacceptable for any member of public or a member of their family to physically or verbally abuse any member of staff who's trying to help them. There were 459 incidents between April and December last year, which is roughly 2 a day, of members of the public either being physically or verbally violent to our staff. That is unacceptable. And to those members of staff who have to cope with that, particularly when it involves racial abuse as well, can I wholeheartedly apologise. You don't come to work to suffer that, and we will do as best we can to stop it happening. But members of the public, you don't have any right to do that, whatever the excuse is, no matter how long you've been waiting. Our staff are doing the best they possibly can for you. Having said that, any questions to Richard on the audit assurance report? Okay, thank you very much, Richard, and great to have you.
I'll just add to your comment, Russell, that part of the report will come through in due process is a significant increase the number of cameras available, and also security staff will have body cameras, because one of the problems we've got with CCTV, it doesn't record verbal abuse or racial abuse, so that's now happening in the key areas. So I'll be able to report that in due process.
No, that's great, Richard, but the fundamental point is members of society don't have the right to abuse physically or verbally any other member of society. We shouldn't have to wear body cams to have a body of evidence to go to the police. You just shouldn't do it, full stop. So we'll move on then to reports from representatives on projects and groups. And the first is the Ellen Badger Hospital site redevelopment. Over to you, Mike.
Thank you, Russell. So I published a paper which was in the pack, so I'll take that as read. We had a project board yesterday, and the two real takeaways that I noted were that the demolition phase, which is still continuing, is more than just the demolition. It actually includes some of the rebuilding of the boundaries where they'd taken down the old mortuary, and progressing ducts for the electricity cables, and the substation. And the team are also liaising with County Council's highways, who I know Joe loves, about section 278 works, which is the site entrance where it goes onto the public highway. The other takeaway was that Sophie Mason, who's going to be working with the Stour Health Wellbeing Partnership on how the Health Wellbeing Hub is actually designed, has got her first meeting with the work stream leads there next Tuesday. So that'll be interesting and exciting. Happy to take questions.
No, thank you, Mike, and thank you for your hard work on this. Questions or perspectives to Mike? Okie dokie, so we'll move on then. Thank you, Mike. The End of Life Committee update. Michael Coker. Actually, I don't think we've got Michael with us today.
He had just joined us, Russell, but I think he might have disconnected again. I'm not sure if he's got network problems.
So we'll pass over, maybe come back to that a bit later. David, would you be okay to talk to us about the Falls Prevention Steering Group, please?
Yeah. The report is shown. It's there wasn't a meeting. Took an extract from the report that were to be presented. So I'm happy to take any questions on that.
Thank you, David. Any questions or perspectives to David on the Falls Prevention Steering Group? I am absolutely delighted more generally with our Frailty work within the Trust, and it's been wonderful to have Amanda Pritchard, Chief Executive of the NHS, come and visit us on a couple of occasions and use SWIFT as the benchmark on which Frailty services should be considered in other places. So, David, I know over the years you've been very important on the whole issue of rehabilitation, frailty and fall. So thank you for your endeavours. Colleagues, happy to move on to the patient experience group update. And Ruth?
We haven't met. The meeting is next week, so I have nothing to report.
Thank you, Ruth. You looked as though you were being blinded by the light there on your phone. Any questions to Ruth? So move on then to the patient portal group update. Pat.
Have you missed the Patient Safety Surveillance Committee?
Do you know, Pat, I'm glad one of us is paying attention because I did. So the Patient Safety Surveillance Committee, Sue Warner.
Oh, sorry, I just put my camera on. Yes, the January meeting was cancelled because of the pressures on. It's a very high number of clinicians that attend that because of the pressure on work. So we had a meeting on Monday. Very briefly, I'd say there are some good areas where things are improving. Certainly around falls and medication, the positive moves there. An issue around respect forms, that making sure that they're getting out all right, and that's improving. However, it was discovered that one patient had 2 falls, one commenced in the community and one in the hospital, and everyone should only have 1. An issue around the number of pressure ulcers that were going up, and there was a discussion whether that was possibly caused by the wrong equipment or actually being on trolleys in A&E in the emergency department. And also how we measure them, because the report is on the pressure soils at level 3 and 4, but there's also an area called unstageable when they're between the two and you can't quite judge whether they're one or the other, so they're not actually measured within that. So the consideration is whether we should be putting a section in for those as well, the unstageable ones, and that's having consideration. The main issue around the main concern for the Patient Safety Surveillance Committee is around the changes of how it's reporting. Nationally, we're going to PSERV, which is another way of measuring, which I think has to go should be in place by March, I think. But there is a need for all senior managers for each department to undergo the PSERV certified training, and it has to be from a certified trainer, which has a price linked to it, but it also is 2 days training for each of those managers, and it's whether we've actually got the time. Well, we've got the time. Whether we can free them up to actually do it in time. So that's being worked on at the moment. Pat, have I missed anything?
Pat, you're on mute.
I don't think I have. I mean, there's a couple of. There was a long meeting, but those are the main areas of it anyway.
Okay.
I think that's it, Sue.
Okay, super. Thank you, Pat. Thank you, Sue. Questions and perspectives to Sue. Jean?
I heard recently, and I can't remember which meeting, that ambulances do not have pressure relieving pillows, beds, mattresses. I was quite surprised at that, and obviously that's been a feature of recent months, particularly. So with the long waits, and I wondered if that's. I thought I heard that somebody was trying to remedy that. Do you know anything about that, Sue? Because obviously it must contribute.
Not from this meeting, but funnily enough, my daughter is a specialist nurse practitioner within the ambulance service, and she did sort of allude to that fact in another conversation we were having. But she doesn't work in a local ambulance service.
Right.
But no, it wasn't brought up in this meeting. But it needs to be looked at.
Yeah.
Harkamel, do you know what the facts are? Is it the case that ambulances don't have pressure relieving mattresses?
I don't know for a fact, but I would not imagine so. because patients shouldn't be on the ambulances for that long, essentially. We have got toppers though in place in our ED, so mattress toppers that are pressure relieving, because to pick up on the update Sarah gave earlier, recognising that at points we do have patients waiting in our department too long. The tissue viability nurse has worked with us, so we would, in absolute extremis, provide that to the crew on the ambulances, but that hasn't been an issue for us as I've presented for the past few weeks, and I hope that sustains itself.
I'll be speaking with Jo Coatman, so I'll ask her, shall I ask her if she can explore and find out if they're going?
I'd be surprised, Gina. You shouldn't be in an ambulance that long, to be honest. So, it wouldn't surprise me, because they're more expensive, if they didn't sort of invest in pressure relieving mattresses. But if you want to do that for you, then that's fine. It's outside our control anyway.
Yes, will do.
Thank you. Michael, are you back with us, Michael Coker? Okay, so I was incorrectly briefed. Apologies. So we'll move on then to the patient portal group update. Over to you, Pat, hopefully correctly this time.
Yes, it's really just to say there hasn't been a meeting since the last Council of Governors, so I haven't actually got anything to report on that, and I haven't got a date for the next meeting yet. But a thing that has cropped up to me is how to remove incorrect letters on the patient portal. A patient was sent, an outpatient was sent an incorrect appointment. Their appointment was, they were told it was going to be virtual, but in actual fact it was face-to-face. So they never got their virtual, and the clinic never got the face-to-face. So the clinic notified the portal that the patient was a DNA. And then the patient was notified about this letter and then didn't know how to get it removed. And also the letter said that their GP would be notified of that as well. Yes. So I have contacted Patient Portal and suggested that there is some instruction as to how to get this done, because it has to be done by the department.
Okay, thank you, Pat, for doing that. I have to say, I've been using the Patient Portal, and if you're not a technophobe, I find it incredibly helpful. But if you can keep us briefed on how that work progresses, that would be great. Any questions to Pat? Okay, thank you, Pat. Michael, thank you so much on what I know is a difficult day, joining us as you have done. Do you want to give us a quick update on the End of Life Committee?
Well, I did a note on it. The most interesting thing, of course, is the new lady who is joining us shortly. I forgot her name now, but she's obviously going to be very, very helpful in training. And what I would say again is, and I have to mention it because I think it's right, I'm very impressed by the attitude of the professionals on that committee. They are interested, want to make the job done better. And as it happened, and I think I ought to mention this too, I unfortunately had to spend 3 days in the hospital myself over Christmas. And I did see actually end of life in operation for 2 gentlemen opposite me. And it was done very, very well. And that is terribly important, because I think we all expect to go into hospital to get better. Many people obviously die, and it is just as important that they are dealt with properly at that time, and more particularly the families. And families in this particular instance, both cases, were dealt with very nicely and seemed to go away, if you like, content. It's about the best word I can use.
Right.
There we are.
Any questions to Michael or perspectives? Michael, if you can take it forward, I'll let Mary go first. Mary?
Thanks, Russell. It's very quickly, really. Did they make any further mention about the availability of palliative care medicines in the community? Because that seems to be a recurring issue.
As far as that was concerned, they were looking into that and actually joining it far more up with our committee, which again seemed to me to be a good idea. We don't govern it, as I understand it, but they were hoping to sort of join it in together. And again, this is the attitude that they seem to be taking, of looking for improvement rather than just dealing with what you have to.
Thank you, Michael. Thank you, Mary. Just a quick one from me, Michael, because I'm handling it at my end, but you might like to follow it up on through this subcommittee. I was speaking to our chaplaincy services, and one of the things that caused me great concern was we find it very, very difficult to get cover from Catholic priests for people requiring their last rites. Clearly, for those of the Catholic faith, that is an enormous issue. And so I'm working with the chaplaincy to see what we can do from our side. But it, I think, is one of those issues that for families and for individuals who are Catholic, not being able to receive the last rites from a Catholic priest because there are no priests available, it is a big issue. So could I just ask you to log that in your memory bank to take forward to that?
It's not difficult because I'm a Catholic, so I would be very keen.
No, absolutely, and I'm not a Catholic, but I'd be very keen for. I do like the idea of those with a spiritual faith being in distress at the end of life. We should do everything in our power to support them, and we have a wonderful chaplaincy, but I know that is a real issue. Sharon's put in the point about therapy dogs and cats can visit end of life. Certainly, I've already said to my wife, when it comes to my end of life, I want my Bible in one hand and my dogs by the side of the bed. But we'll move on. We're running a couple of minutes late, but we're up to the the Safer Discharge Group update. Jean.
Well, there isn't one really, or not an official committee meeting. They've moved it to every 2 months because of the pressure of work, and then they've had to cancel at quite late notice because they're just so pressured. But as you'll see in the patient care committee, in actual fact, they are obviously still dealing with issues to do with discharge, especially to do with pharmacy. And Mary has been invited to join the pharmacy committee and has also met with head of pharmacy. And there was quite a discussion at clinical governance yesterday with the head of pharmacy. So so they are looking at issues to do with, they're just not meeting as a committee. Bless them, because they're just so under pressure.
Thank you, Jean. Any questions to Jean? Okay, thank you for your hard work, Jean. The Wayfinding Strategy Group update, there's a 2-page in the pack. Roger, anything you'd like to add?
Only to say that in view of the elective hub finance coming on stream, there will obviously be a considerable amount of work to be done to make sure that people can effectively navigate round the hospital, round the works once they get going. And one significant point tying back with the patient portal is to make sure that the patient letters and the signage use the same name for each particular location, because in some cases there are duplicate names or different names for the same place. We're on to it. Everyone will be trying to get commonality for the names and the letters.
No, that's great, Roger. And that might sound a trivial point, but I know from talking to patients and their families, particularly if they're rushing, they found it difficult to park, they're in a rush, the confusion over where to go, it can be enormous, particularly if you're of a certain age. Questions and perspectives to Roger? Callie?
Obviously, we're talking about the elective care hub. Is that the case? Is that?
Yes.
Yeah.
Yes.
That's it. You attending this group alongside Graham, or is that, or Graham Nuttall? No.
Graham is my deputy on this.
Okay, sorry, yeah.
On this group.
Okay, that's okay. That's all right. It was something in the report about 7 key risks when it comes to the elective care. They've been identified. Around what sort of risks these are. Are you aware? That's what I read in the report. So
I think we're on the wayfinding strategy group here, Callie.
Oh, sorry. Okay.
So we'll maybe come back to that question a bit later. Thank you.
Okay.
So moving on then to the elected care group update. Thank you, Roger, for your hard work on wayfinding. Graham, over to you.
Yes, thank you very much. I have provided a written report. I mean, the main highlights on this are the discussion that they had about the retail offering within and the procurement for that. I think there's further work to be done on that. And also there was quite a lengthy discussion on the within the clinical work stream about change ways of working once the building is completed. I think we need to not underestimate the amount of work that is going on and the complexity of this as a project. And I take my hat off to them, particularly with all the moves that are going on.
Thank you, Graham. I mean, it is very, very difficult in a site as physically constrained and with different ages as ours to do this. The team are doing a great job. The 7 risks, which is on your risk log point. Can you recall what?
No, sorry, I must admit I can't recall what the 7 were. I can reply to Callie outside of this, but once I go back to my notes.
Okay, thank you.
Thanks.
Super. And any other questions to Graham? This is a really important piece of work strategically for the Trust and for our ability to drive through the waiting lists for our citizens. So thanks for your hard work in supporting the team, Graham. I will then move on to governance matters. And the first is the Patient Care Committee report and draft minutes for November, December and January, which are obviously in the pack. Is there anything you particularly like to pull out, Jean?
Just to say how enthusiastic they are, what a wide range, because I was chair some years ago, and we've now got a really wide range of clinical expertise plus other users, and it's a really good mix. So I'm quite pleased with that. We also meet on a monthly basis, which other committees don't, because we try, or we are, meeting the week after clinical governance, so that what they hear and what we discuss is very live. And having Dr. Spraggart and Sarah there is very helpful in making sure that they're very assured about current issues. And we also, which we'll go on to later, had quite an in-depth and enthusiastic discussion about quality targets and about the governor one. But that's it. Thank you. You're on mute.
You're on mute, Russell.
Thank you, Jean. Schoolboy hour. Wouldn't be the same if I didn't do it once in the meeting. Roger?
Yes, there's a comment, Jean, about the ICB wanting still to appoint PSPs at a system level. Who, why, when, or what are these?
I've got no idea.
Sarah? Moffat?
I might be able to help, Jean. So I think, Roger, what you're referring to is part of the rollout of PSURF, so the new patient safety framework, which is going to replace the serious incident framework that we've got currently. And as part of that, just tell me the letters again and I'll tell you what they stand for.
Yes,
Patient Safety Partners. That's it. And so that's members of the public that undergo some training in order to be able to assist us in exploring learning out of when clinical things don't go as planned. So there has been some debate. Our system decided that they were going to create a bank of patient safety partners that organisations could sort of pull from when they needed them to join investigation teams. And I think they are now thinking that we may do that at an organisational level. So I think Chris Day, our head of governance, is going to a meeting shortly where that's going to be finally decided. We're a bit anxious about the change in direction because, as I think it was alluded to earlier on in the meeting, we're supposed to really have some of the structures in place by the beginning of the next financial year. So it's not giving us a lot of time, but we will find a way to navigate, because these are really important roles that I think will support us just developing our investigation of serious incidents to consistent with our values and our culture, and becoming more open, more transparent, more emphasis on learning from themes. So I think involving patient safety partners is really, really important.
Thank you, Sarah. Conscious of time, thank you for the question, Roger. Thank you, Jean. But in terms of the local quality indicator, what decision do we need to make, Jean?
In terms of the two that we put forward, we haven't been able to actually finalise them because of the pressures in A&E. But I've now spoken with Jenny Nichols. Her team have sent quite comprehensive replies about the difficulties, and she's in London today, and we're going to meet when she returns. So that's the A&E target, which they would like to bring in, but there are quite a few difficulties which they detail. The other one is the patient falls, prevention of falls before people actually come in to hospital. And we've tried to do this previously, but there were issues to do with public health and finance at the time. Jo Coatman and I are meeting after she's had her holiday, and we're going to go through that with them. It's definitely doable. There's no problem about that. And Sarah's very supportive.
Yeah, but Jean, at the moment, we're not able to make a decision because you're still in discussion, aren't you?
That's right. But Sarah did do quite a lot of work with a lot of people last September, and they are ready and sitting ready.
Yeah, but as a Council of Governors, we're not in a position yet to sign off, are we? So can I suggest, Jean, when you're in a position to have finalised all of those discussions, let's try and make this happen before the next Council of Governors, given the start of the financial year. So maybe you, I and Mary can talk about sending an email to all governors, which governors can either agree or disagree with what you're recommending, so that we can implement it before the next Council of Governors. Are you happy with that, Mary Malloy?
Yes, that's fine. So, and in the meantime, we can be, as we have monthly patient care committees, we could take that forward through the patient care committee if we want to discuss it at any more length, because I do have some concerns, but I'll take those to the patient care committee.
Okay, so we'll keep all colleagues briefed. Callie, your hand's gone up again. Is that
just a clarification, because obviously in the report that we have, there are about altogether, there are about nine indicators. These have been discussed at the patient care committee, and they decided on the top two. Is that what is the process to decide the local quality indicator for the quality report? Because there are nine indicators.
I thought I'd explained that I didn't want to just say, well, they're not relevant or we don't care about those. I just wanted to make sure that everybody knew each of the things that people had put forward and that they were relevant but not doable at this time, and everybody agreed on those two that I've just outlined.
Okay, sorry, I didn't hear that. Cheers, thank you.
Thank you, Callie. Thank you, Jean. Thank you for your hard work.
Just to clarify, Russell, that it is actually the Patient Care Committee's remit to identify this and then bring it to council. Yeah.
Correct. Yeah. We'll move on then to the GPC report and draft minutes. Running a few minutes late now, so we can try and pick up. Mary, over to you.
Thank you. Yeah, well, I take the minutes as read, and I apologise that they're a bit long. So I have actually picked out a few highlights to make life easier. In addition to setting the Council of Governors agenda and the training programme, it was agreed that a meeting between new non-executive directors would be arranged individually with the governors as part of the non-executive directors' induction process early in their appointment, so we can get to know them sooner. And perhaps a follow-up meeting a year or so later to see how things are progressing. We discussed the update on the membership and engagement arrangements, and we had a meeting last week, didn't we, discussing the way forward with that. So I think governors are be aware of what's happening with that. It was felt that the chief meetings do not involve members of the public and therefore don't currently meet our needs. The Council of Governors self-assessment was discussed and the lessons learnt, and some suggestions have been made as to how we might improve. An extraordinary general meeting of the general purposes is being arranged. Sarah's working on that at the moment so that we can discuss the roundtable agenda. We haven't had time to discuss that at our meetings previously, so we're going to have a special one-off meeting. We discussed the survey, the induction process at some length, and some governors are still unsure of their role and how it would be carried out. So we were discussing ways that we could actually improve that situation. We thanked Sophie for all her work on this, because an awful lot of work went into this induction programme. And Sophie has kindly agreed that she'll continue as the induction lead governor going forward. The general purpose terms of reference were amended to state that the trust chair will be my deputy, and I expressed concerns that the committee is unable to fulfil its terms of reference at the moment, because a large part of it is around membership recruitment and engagement. So we've agreed, once we've finished the discussions on that topic, we'll review our terms of reference again, and hopefully that will be removed in the future. We were then went on to review the committee of the membership of working groups and committees. And Sarah's already written out to governors asking if they wish to continue on the committees that they're already on. And when we've collated all that, we'll be able to see if there are any gaps and find some way of ensuring that all our new governors are at least on one of the committees or working groups. We agreed that it wouldn't currently apply to staff governors, because we wouldn't expect them to be on committees or working groups with the pressures that they're under at the moment. And you should have all seen the updated training programme on admin control. So the final issue that I want some kind of discussion agreement on is an email for governors to send out to their contacts, friends, family, colleagues, groups, whoever they meet in their world, to encourage them to join the trust as members. And this came out with the papers. So I'd like to actually ask for any comments or suggested amendments and ultimately approval of this email that we'd like to use to send out to encourage recruitment. I'm happy to answer any questions on GPC and then discussion on the email.
Okay, thanks, Mary. Someone's sharing their screen, which is going to cause issues for members of the public. Who do we think is sharing the screen? Can you raise your hand?
I think it's Michael Coker.
Okay, Michael, you seem to have shared your screen, which has caused a split screen for us all. Sarah, maybe separately you can help Michael know how to undo that.
I'll put the instructions in the chat, Russell.
Okay, thank you. That's not worked either, getting all sorts of funny things coming up on the screen. So just bit by bit, Mary Malloy's briefing on the GPC highlight. Any questions on that? I'll come back to the email in a second, please. So thank you for that, Mary. No,
I've lost everything on the screen altogether. Has everybody else got anything on their screen?
Mary, but let's just carry on, otherwise we'll be here all day.
No, mine's gone as well.
Oh, okay. I thought it was numbers. It's mine. Okay.
So can we just carry on, guys, and we'll sort it out behind the scenes. So the second question you had, Mary, was about the email that you circulated. I think probably the easiest thing here is, does anyone object to the draft email that Mary circulated? If you do, please raise a digital hand. Okay, normal services resumed, super. So I think, Mary, that's good to go. So thank you for doing that. Mary, is there anything else you wanted covered?
No, that's fine. We'll get this. I'll get back to Mary Powell and get that in circulation. So yes, no, that's fine. Thank you.
Okay, great. Thank you. So moving on then, we've got the annual review of committees' terms of reference. Sarah?
Thanks, Russell. So it's the 3 subcommittees of the Council of Government terms of reference. They've already been through the committees and the proposed amendments are shown as track changes. So it's if the council's got any further amendments before ratification. Thank you.
Thank you. So any questions or perspectives on those review of committees' terms of reference? Please raise a digital hand. Mary Malloy.
Yeah, I haven't got it in front of me. I've already explained about the General Purposes Committee terms of reference, but my question was around the Patient Care Committee terms of reference. It mentions that the Director of Nursing would be invited to attend. I just wonder why the Director of Nursing or Deputy weren't members of the committee.
That was the wording I had through from that was agreed at Patient Care Committee, Mary. So I don't know whether Jean can answer that one.
The reason being that's desirable, but because of all the issues to do with pressure at work and everything, it's actually been quite difficult to achieve. So we can put it in the terms of reference that it's a requirement, but bearing in mind that there are difficulties in terms of attendance. So happy to change the terms of reference so that it's required, but as I say, in the real world, it's not always achievable. So I'm happy to do whichever you say, Russ.
Putting in the membership doesn't mean that they're required to come. It means that they are a member of the committee. They can always send apologies or a deputy. It's only if it's in the quorum that you need that they need to have to be there.
Right. It wasn't mentioned when we all agreed it, but I'm happy to change it.
Okay, so just if you're a member of the Patient Care Committee and you object to the Director of Nursing or the Deputy being a member, please raise a digital hand. Can you take your hand down, Mary?
Oh, sorry. I don't object.
So I think that's agreed. So if we make that amend, Sarah Colette, then that's good. So out with that change, are colleagues all happy to sign off those terms of reference? Please raise a digital hand if you're not.
Oh.
Okay, great, thank you. So they're duly approved. Super. So we'll move on then to the report on resignation and appointment of governors. Back with you, Sarah.
Thank you, Russell. Happy to take the report as read because I think it's self-explanatory, and if there's any questions, thank you. Russell, you're on mute.
Any questions to Sarah on that report? Thank you. So we're then on to the Chair and Non-Executive Director Remuneration Review. Roger? You're on mute, Roger.
Right. Sorry. Right. I think the report is straightforward. It's a sensible approach in that we are not pushing the envelope too far, but making it a sensible median approach. And I would invite anyone to raise any questions.
Questions or perspectives to Roger? Okay, thank you, Roger. Very clear. So we move on then to any other business. Any other business from governors, including questions from governors? Roger?
Yes, in view of intelligent conveyancing and load balancing, with ambulances moving from one acute provider to another due to delays in offloading and doing it in block almost, what progress has been made in securing additional funding for SWIFT, as clearly our block funding for ED is based on our geography and not on the footprint of the entire West Midlands Ambulance Service. We're providing A&E services for a very large area, including east of England, so presumably Leicestershire.
So I believe I'm correct in saying, Kim, that there's no progress on that issue. It's a block arrangement and it is what it is. Can you just nod to confirm, Kim? So there's no progress on that, Roger. There won't be any progress on that. I think we are lumbered with it, so to speak, financially. So unfortunately, I can't give you any assurance that that will change, because I don't think it will.
Okay, right, well.
Best to be straightforward on this type of stuff. Pat?
Yes, our doctors taught listening skills. The reason I ask is because several reports of late that I've received have had so many inaccuracies that one I didn't think actually referred to me at all. I thought it was another patient.
Well, I'm sorry to hear about your experience on that, Pat. As I understand it, we don't have BASCA or any clinicians with us. There are elements of the doctor training which includes listening. There's also elements which include how to handle end-of-life type discussions. But I have said to colleagues in universities that I don't think either of those elements are significant or strong enough, given what I observe on occasion as to conversations that occur. So sorry for the experience you've had, but there is some element of training on that, but I don't think it's enough.
Thank you.
And then Mary Malloy.
This is something that Roger has raised with me in the past, I think. It's about the provider licence. There's a phrase in there that says criteria agreed by Council of Governments with the board in the light of conditions on the provider licence. And I don't know whether I'm just out of touch, but I didn't know about the provider licence. And I just wonder whether you could give us a few words on that, Russell.
It's a change in the legislation, as I understand it, Mary, that in the past we haven't had to. So if, for example, you're Nuffield or Spire, you have to sign off a provider alliance assessment. We haven't had to do that previously. We are having to do it going forwards. So we will ensure we've got to do it going forward. So it hasn't been a previous requirement, Mary. I think that's why it's appearing now.
Thank you. So that will come back to us at some stage.
Right, at the appropriate cycle. Sarah Collette, is there anything I've misrepresented in my answer there?
No, you're right, Russell, and I have shared with Roger that my annual report that I do on the compliance against the provider licence that goes to board annually will then come through to Council of Governors afterwards. So I think that's for the May meeting.
Okay, thank you. I think it's a good thing, Mary. I think all providers should their boards should sign off formally their assurance about meeting all of the requirements of the provider alliance or provider license. Okie dokie, and Jane, and then we'll draw the meeting to a close. Jane Knight.
Thank you. The reason I'm asking this is that we were asked in an email to send questions from governors, and I can't remember which meeting it was for, but I haven't had any answer to any of the meetings I've been at lately, so I'm not sure whether it was for this one. Basically, I just asked for an update on the haematology department and on the endoscopy department, because there were issues some time back, and I wondered if they've been sorted.
Okay, not sorted, but Harkamel, do you want to give a quick update if you're there?
Yeah. So for haematology, we are continuing to work with the team. So me, Sarah Baskar, the clinical team, the management team, and actually we have a clinical summit coming up in a couple of weeks, or is it next week? It's next week. Just to go through with the clinical teams the incidents that have been raised, some of their concerns that they've got, and then alongside the work programme that we've got anyway. So for me, haematology has got quite a robust structure around it, and there's quite a lot of work ongoing to make sure that we retain focus on that. Is that what you meant with haematology?
Well, thank you. Yes, good luck with that. I hope it gets resolved soon.
Thank you.
Then in terms of endoscopy, I am not entirely sure which issues you're talking about, but generally they're doing really well. Endoscopy capacity has increased significantly, and that's really supporting some of our elective recovery. So I'm not sure if there was a specific issue that you were thinking about.
If there was, Jane, maybe get back to Harkamel through me, and we'll address any specifics.
Yeah, I'm more than happy to look into anything.
Okay, great. Thank you. Okay, team. Well, that's the end of the meeting. I look forward to seeing you at the next meeting, which is on the 11th of May, members of the public. For governors, let's have a 5-minute quick stretch break and we'll get into confidential minutes. So a 5-minute stretch break. See you soon.